going to start off today's overview with a look at the measures NCQA is proposing to add and retire in measurement year 2026. The first new measure we will review is an electronic clinical data systems measure called Tobacco Use Screening and Cessation Intervention. NCQA proposes this measure to replace the Medical Assistance with Smoking and Tobacco Use Cessation, or MSC measure, which is calculated based on member responses to the CAPS survey and would be retired in favor of this new measure. This would apply to all product lines for members 12 and older that are continuously enrolled through the measurement year and the 180 days prior. Only an age stratification is proposed, and one of NCQA's public comment questions is specifically looking for feedback on the proposed age groupings. Members who are deceased or in hospice during the measurement year would be excluded. The tobacco use screening metric only requires the proper age and continuous enrollment for eligibility and evaluates of those members which have been screened for tobacco use and identified as a positive or negative tobacco user anytime in the measurement year. For compliance, the member would need both a LOINC screening code as well as a specific response code that indicates whether they are a tobacco user or non-user. According to the proposed value set directory, the available response codes can either be LOINC answer codes, SNOMED codes, or ICD-10 diagnosis codes. However, the ICD-10 diagnosis codes are only found in the positive tobacco users value sets. Negative tobacco users can only be identified using LOINC answer or SNOMED codes. We recommend evaluating your current EHR data sources for the proposed LOINC answer and SNOMED codes to be able to identify tobacco non-users, as without those codes, you may only be able to calculate screening compliance for tobacco users. NCQA is specifically requesting feedback on the adequacy of the value sets for comment. The denominator of the cessation intervention metric would be a subset of the members who are compliant for the screening numerator, containing all members who had a screening and were identified as a positive tobacco user between January 1st and December 1st of the measurement year. For those members, they would be considered compliant for cessation intervention if they received one of the following services anytime in the measurement year or in the 180 days prior to the measurement year. For anyone ages 12 or older, they would be compliant if they have evidence of tobacco cessation counseling. For members 18 and older, they could alternatively be compliant with evidence of dispensed pharmacotherapy intervention for tobacco use. The next proposed ECDS measure for 2026 is follow-up after acute care visits for asthma. This measure is proposed to replace the existing asthma medication ratio measure, which would then retire in 2026. Notable here is that the AMR measure today, given its reliance on pharmacy data, only applies to products that offer a pharmacy benefit. However, this new proposed measure only requires a medical benefit for eligibility, meaning that products that have not historically reported the AMR measure could then be eligible for reporting this new measure. It's proposed for the commercial and Medicaid product lines for members ages 5 to 64 as of the episode date. Members would need to be continuously enrolled on the date of the eligible episode and the 30 days after. NCQA is proposing two different stratifications for this measure, one by age groups and another based on whether the member has been diagnosed with COPD anytime in their history through the end of the measurement year. To identify the initial population, NCQA is looking for ED visits, urgent care visits, acute inpatient stays, or observation discharges that have a principal asthma diagnosis between January 1st and December 1st of the measurement year. Of note, in the draft spec, NCQA indicates that observation discharges that are missing admit or discharge dates can utilize the earliest and latest dates of service on the discharge claim as a proxy for admit or discharge date as needed. This is notable as previously this guidance was included specifically in the general guidelines for risk-adjusted utilization measures and otherwise did not apply outside of the risk domain. A member could be in the measure multiple times if they have multiple eligible episodes, though NCQA plans to exclude ED visits and urgent care that result in an inpatient or observation stay. They also propose deduplicating multiple eligible events within a 30-day period, only using the first of the eligible events in that time frame and excluding any additional events in the 30 days after. NCQA will request comment on whether this eligibility criteria should be limited instead to only ED visits, removing urgent care visits, inpatient, and observation stays. Events can be excluded from the denominator of this measure for members who are deceased or in hospice during the measurement year, or members who have had acute respiratory failure, emphysema, or cystic fibrosis anytime in their history through the end of the measurement year. NCQA is also requesting comment on whether these diagnoses are appropriate exclusions for the measure. For an eligible episode to be compliant, a member would simply need to have an outpatient or telehealth visit in a non-urgent care setting in the 30 days following the eligible episode, not including the episode date. NCQA is requesting two different areas of feedback on the proposed numerator criteria. They're interested to know if follow-up visits should have any other specific setting or provider type limitations. They're also considering shortening the compliance window to only 15 days following the episode date and would like feedback on the appropriateness of that as well. The final new measure proposed for 2026 would be a health plan descriptive information measure called Disability Description of Membership. Similar to the existing race, ethnicity, and language measures, RDM and LDM, the DDM measure would look to report on the availability of disability data for members. NCQA proposes limiting the reporting of DDM to members 15 and older due to age limitations on disability questionnaires, though they note they are evaluating methods to report on disability data for children and adolescents in the future. They're requesting public comment on this age limitation as well. The measure would apply across all product lines, and a member would need to be enrolled for at least 1 day in the measurement year to be eligible for reporting. NCQA proposes two different groupings of stratifications for this measure. The first by a combination of disability status and data source, and the second by disability type. The first stratification would group members into disabled, not disabled, or missing disability status, additionally stratified by the source of the disability status. The proposed disability data sources include self-reported questionnaire, self-reported accommodations, and enrollment status. Only a single source of disability data would be reported per member, and the plan would be responsible for determining a hierarchy of source accuracy, as well as determining a method of reconciling disagreements between different sources of disability data. NCQA is requesting feedback on the appropriateness of their provided data sources for reporting. The second stratification would take the disability statuses and break them down into more specific functional disability types listed on the slide here. Members could be reported in multiple disability types for this stratification. Note that this measure does not have any value sets or specific recommended ways to capture and report this information. The organization is expected to take any internal methods of identifying member disabilities and translate that into NCQA's provided categories and sources accordingly. We recommend looking into whether this type of data is available in any of your internal systems that could be extracted for HEDIS reporting, as well as collaborating with your certified HEDIS vendor on how this data can be ingested into your HEDIS engine. NCQA is looking for comment on whether the measure should include disability type reporting or not. They're also looking to know if they should have a specific list of disability accommodations for reporting in this measure, and if so, which they should include. Now that we've reviewed the proposed new and retired measures for 2026, we will step through the proposed measure changes for 2026, as well as NCQA's notification of finalized changes for both 2025 and 2026. First, we'll cover the proposed changes to the adult immunization status measure. The primary change proposed is to add a sixth numerator, evaluating whether members have received their annual COVID-19 vaccine. Eligible members need to be 19 or older at the start of the measurement year and have continuous enrollment through the measurement year, following the same eligibility criteria and age stratifications as the influenza and Tdap numerators. To be compliant for this new indicator, the member would need to have received a COVID-19 vaccine on or between July 1st of the prior year through June 30th of the measurement year. A member is also compliant if they've experienced anaphylaxis due to the COVID-19 vaccine anytime in their history through the end of the measurement year. In the proposed value set directory, NCQA has a list of suggested CPT and CVX codes for identifying COVID-19 vaccines. We recommend looking into your current immunization data sources to see if you have the proposed codes present in your data today. NCQA notes that they are looking for overall comments on the new COVID-19 numerator. Within the provided draft specifications, there are also other changes, though NCQA does not specifically call them out in their request for feedback. These changes include updating the zoster compliant range from starting on October 1st, 2017 to instead starting on October 20th. NCQA also updated the data elements for reporting table to remove the breakout of data by source systems of record, which are the IDSS data elements split out by electronic health record, HIE and clinical registry, case management system, and administrative data. We'll dive into that change a few slides from now when we cover some of the more cross-cutting changes from the public comment. NCQA has also removed their guidance about identifying the date of the procedure for SNOMED codes. We anticipate this is due to one of their notification of final changes we'll be covering later related to the removal of SNOMED codes from immunization value sets. Next, we will review the measures from the public comment that NCQA is transitioning to ECDS reporting. NCQA is requesting comment on the retirement of hybrid and administrative reporting of the lead screening in children measure, transitioning the measure to ECDS reporting only. This differs from the details NCQA published last fall regarding their hybrid retirement timeline, where they indicated that the LSC measure would retire hybrid reporting and transition to administrative only. The main difference we see between administrative versus ECDS reporting for LSC is that the ECDS specification does not split out numerator results by administrative versus supplemental compliance, but rather combines all of the data sources into a single numerator for reporting. NCQA is also planning to transition the statin therapy measures for patients with cardiovascular disease and diabetes to ECDS only. These two measures have several shared changes proposed for 2026. They are looking to remove the exclusion for members enrolled in an institutional SNP or living long-term in an institution and are requesting comment on that change. They are also planning to rename the ischemic vascular disease criteria to atherosclerotic cardiovascular disease, which is a component of the eligibility criteria for SPC and the exclusionary criteria for SPD. We plan to simplify the requirements for this criteria by requiring just 2 diagnoses on different dates of service anytime in the measurement year or a year prior. This would remove the need for additional setting type codes with the diagnosis, as well as remove the limitation that 1 diagnosis must be in the year prior and 1 in the measurement year for eligibility. NCQA is requesting feedback on this change for both measures as well. While NCQA notes that these measures are moving to ECDS reporting, this specific change is actually not up for comment. They've noted in their notification of changes that the move to ECDS reporting for these 2 measures is final. The takeaway here is that this transition opens up the event diagnosis logic for identifying eligible members for both measures to allow for the use of supplemental data sources. To assess potential impact of the transition of these measures to ECDS reporting, we recommend evaluating your supplemental data sources for the presence of cardiovascular disease and diabetes diagnoses. The SVC measure has 2 additional proposed changes as well. NCQA is planning to remove the sex-specific age criteria for the measure, which would expand the eligible members from ages 21 to 39 to include now females and other gender identities. They also plan to expand the upper age limit of SPC to 85 from 75. NCQA is requesting feedback on both of these proposed changes for SPC. Next, we'll look at measures with proposed value set changes. The social needs screening and intervention measure, NCQA is looking to provide additional avenues to identify intervention needs, as well as screening and intervention compliance. They're planning to add HCPCS G codes to both the screening numerators and the intervention numerators. They're also planning to add ICD-10 Z codes for determining members eligible for interventions. This change will reduce the measure's reliance on LOINC answer codes to be able to identify members with unmet social needs. We recommend evaluating your data sources for the presence of the proposed G and Z codes to see if this change may impact your results for SNSE. NCQA is also requesting feedback on the added codes as part of the public comment. They're planning to take the screening assessment codes out of the intervention numerators, indicating that these are more appropriately assessed as part of the screening numerators instead, and would like feedback on this change as well. Within the draft SNSE specs, NCQA also notes they're removing the source system of record breakout for the exclusion data elements. However, they still show the numerator data elements broken out by SSORs. This change, while not specifically requested for comment, appears inconsistent with other ECDS measures included in the public comment, so we plan to address that in our feedback. NCQA is also looking to alter the compliance criteria for the follow-up after high-intensity care for substance use disorder measure. The proposed changes for the FUI measure are in alignment with changes NCQA recently made to similar follow-up measures, FUH and FUM. For FUI, NCQA is planning to allow substance use diagnoses that are used for compliance to be present in any diagnosis position on the claim, rather than requiring them specifically in the principal position. They also plan to add peer support services as a numerator compliance option. Finally, they're planning to remove pharmacotherapy dispensing events as a numerator option, citing that filling the medication doesn't effectively indicate the member is in compliance with their treatment for substance use. While the first two options are likely to increase your compliance for FUI, we also recommend reviewing how many of your members are compliant today due to the pharmacotherapy numerator option to help balance out the potential loss of compliance against the gains from the other changes. NCQA is requesting public comment on all three of the noted changes here for FUI. Close out the proposed changes for 2026. NCQA is recommending a cross-cutting change to the reporting of member race and ethnicity. Yet another significant alteration to race and ethnicity reporting. This proposal would see the stratifications combined instead into a single stratification of race and ethnicity data into one table. The existing ethnicity reporting table would be removed, and the Hispanic or Latino ethnicity option would be added to the race table. The white race would be split out, moving the Middle Eastern or North African races into their own separate reporting option from white. They plan to remove the word other from the Native Hawaiian or Pacific Islander race. The some other race option will now include and or ethnicity, and the two or more races option would be renamed to multiracial and or multi-ethnic. NCQA is requesting overall comments on whether organizations support these proposed revisions, as well as looking for organizations to share insight into how recent OMB guidance will be implemented by plans in time for OMB's 2029 deadline. We also wanted to pull together some information from what's been communicated by NCQA regarding upcoming changes to the HEDIS Volume 2 specification structure, as some of what we see through the public comment provides further insight into potential updates. There are several data element changes incoming with the next set of specifications. As we mentioned on prior slides, NCQA appears to be doing away with the breakouts of initial population, exclusions, and numerator data elements for ECDS measures by the source systems of record. Additionally, NCQA has communicated they were planning to replace the term eligible population instead with initial population in all measures. However, from the public comment materials, it seems they've renamed eligible population to denominator and then added a new data element for initial population, a net increase in data elements for non-ECDS measures. NCQA is also renaming required exclusions to denominator exclusions in the spec verbiage, but in their data elements for reporting, they're renaming them to just exclusions. NCQA is also moving forward with their moving the general guidelines into the guidance section of each measure specification, which we can also see a preview of within the public comment materials. They have communicated that this change is not expected to impact HEDIS results or measure calculations. However, we have seen recently that efforts to replace general guidelines with in-measure text has had an impact on measure implementation. For example, NCQA moved the lab data general guideline into the measure specs directly, but in doing so, they changed the approach from only value sets with LOINC codes can use lab data to instead be value sets with diagnosis codes cannot use lab data, which is a material change in implementation across all measures. Finally, NCQA is also looking to alter the verbiage in their specs to be more applicable for a wider variety of use cases, removing plan-specific terminology, such as replacing the word member with the term person. The last set of changes we'll cover today are the changes NCQA has finalized for the 2025 and 2026 measurement years as part of their notification of changes included at the end of the public comment materials. For 2025, NCQA will be adding members who are 42 to 51 years old as of the measurement year to the breast cancer screening measure, as well as implementing an age stratification that splits out the results for ages 42 to 51 and 52 to 74 accordingly. NCQA is also going to be removing the RAND table for sampling from the 2025 Volume 2 specs. They will be re-releasing the RAND table in October 2025, just prior to 2025 production samples being generated. We know that some plans have historically utilized statistical analysis to select their sample sizes, but this change by NCQA will likely reduce a plan's ability to predict which members will be part of their samples in advance of the production season. For 2026, NCQA has indicated they will be removing SNOMED codes from value sets for laboratory tests, imaging studies, and vaccinations, which we saw beginning evidence of with the draft AISE measure spec. We also discussed in the prior slides regarding the changes NCQA is making to their Volume 2 spec template, as well as their transition of SPC and SPD to ECDS reporting. Finally, they note that they will be introducing optional ECDS reporting for the blood pressure control for patients with diabetes measure. This aligns with the timing NCQA provided in their hybrid retirement timeline for the release of a BPDE measure. We were, however, surprised to see that NCQA did not include a draft version of the BPDE measure within the public comment materials. Now that we've reviewed the proposed and finalized changes for the next 2 measurement years, let's wrap up some next steps you can take on the public comment. For those of you involved in drafting and submitting public comment responses for your organization back to NCQA, I highly encourage that you pay close attention to the small details within each proposed draft specification. The public comment is our opportunity to share any concerns or feedback we have with NCQA regarding their proposed measures and changes, and even minor items are worth calling out in your feedback to ensure that the final specs are clear and accurate. For example, does NCQA's Summary of Changes section in the draft spec clearly detail all of the changes that were made? We've seen that when the Summary of Changes is not fully comprehensive, it can lead to missed changes in measure implementation and in certification that can be impactful to plans. We also recommend reviewing the data elements for reporting tables within each draft spec. In our review, we've noticed some inconsistencies in the data element implementation, which we will be sharing with NCQA in our comment feedback. Reviewing the guidance section will also be important going forward, since NCQA is moving the general guidelines from the top of Volume 2 into each measure spec directly. Make sure that all of the expected general guidelines you'd anticipate to impact a measure are present in the draft guidance section accordingly, such as the 14-day rule in AISE. We highly recommend that plans analyze the public comment value set directory as part of your public comment research. The draft value set directory doesn't download if you downloaded the all public comment materials PDF, so you have to specifically download the VSD from the public comment website separately. Working with your data teams, this is your opportunity to see if the proposed codes exist in your current data feeds to begin to understand whether you're able to source the data NCQA is expecting, as well as whether the removal of certain codes may be impactful to your results. While it may be obvious that the final step would be to share your public comment takeaways and concerns with NCQA, through their public comment portal. We also highly recommend you circulate your findings internally with the folks involved in NCQA and state reporting to begin to brainstorm potential changes that your organization would need to make, such as finding new data streams. I also personally encourage that health plans reach out to your client representative for your certified measure vendor to connect on your top public comment takeaways and concerns. Just like plans are looking to understand the impact of these changes, your measure vendors are doing the same and beginning to brainstorm ways they can code to the proposed changes and new measures. If you proactively collaborate with your vendor in advance of their implementation of new measures, that will allow them to consider your suggestions and feedback within their design. Thank you all for your time today to review the HEDIS public comment materials. We were able to review NCQA's proposed changes, suggest some topics to consider when providing your feedback, and give you some takeaways to dive deeper into some of the impacts these changes may have on your organization. I look forward to coming back here again in September to discuss the initial version of the Volume 2 specs for 2026 to see how our public comment feedback impacts the finalized specs for next season. I'll now turn it back over to Cassie to review the upcoming webinars in our Quality Decoded series and close us out.
Thank you, Samantha. Such great information. On your screen now is a QR code to register for the other webinars in the Quality Decoded series featuring Samantha and other experts from Cotiviti's Quality and Stars team. If you haven't already, you can register for any or all of the rest of the series. We also post the on-demand recordings at this link and in the Cotiviti.com knowledge bank.